Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. To Melanoma Matters, I'm James Larkin.
I'm Sapna Patel.
So today we're going to be talking about Relativity 48, which was presented at ASCO fairly recently by Patel. It's quite an interesting study, I think, for a few different reasons. But let's just do an icebreaker, sort of quick fire warm-up question, Sapna, which is going to be, tell us what you're watching on TV at the moment.
So the proper answer is supposed to be, I don't have time to watch TV. I also
take that all that stuff as read. Yeah.
Okay. And then at home, I'm just watching off of an antenna. I'm trying not to have cable TV. So that's one thing. So that means what you get on antenna is all the old reruns of CSI Miami, CSI New York. So CSI Miami is my thing at home. And then streaming, I somehow have gotten into this show, Buying London, which is essentially real estate pornography in your neck of the woods. So that's what I'm watching.
So why are you trying not to have cable?
Because it's expensive. It's expensive, and truly, I'm not watching that much television at home. I need the news, and I need some white noise when I'm cooking or cleaning. And that CSI Miami serves that purpose, and a little bit of other things that are on the TV. And I get the news just fine with antenna. So
really?
Yeah.
Sometimes, they have these subscriptions here. I don't really know how it works in the US, but the other day, there's a new South Park. I don't know. We haven't talked about this, about Ozempic, right? Right.
Yeah.
So anyway, it's only on Paramount. And to get it, you have to subscribe to Paramount, but it's £2 a month for 3 months. So you just do the £6, okay? And then you put a note in your diary afterwards to cancel it. And then straight away you get, and it's, have you watched it or not? It's quite funny. Yeah, as you can imagine, Eric Cartman goes on Ozempic. But I'm afraid it's a parody of the US healthcare system in substantial amount. But anyway, you may enjoy that. Okay, so yeah, well, okay. So what about Relativity 48 then? So do you want to talk us through that?
Yeah, so Relativity 48 is a study that us in the melanoma field have been waiting quite a long time to hear results on. We'd heard that this study was going on. It was being run essentially in Europe, in mainland Europe. It's a study of triple immune checkpoint inhibitor. So it's Nivo, 480 milligrams every 4 weeks, Rela, 160 milligrams every 4 weeks, and Ipi, 1 milligram per kilogram every 8 weeks. So it's not a dose that we had really used in any of our known regimens in melanoma, but the idea was if we have this standard dosing of Nivo-Rela, by the way, I'm not convinced this was fixed dose, but we could look at that for a fact check. Nivo and Rela in the doses that are in the fixed dose drug with this Ipi combination, non-randomized phase 1-2 study, 46 patients in it, and primarily it was to describe the safety. Is it safe to give this triple therapy? And then, of course, some efficacy as well. So objective response rate, disease control, but PFS is what we really heard at ASCO along with safety. So this study had, as I mentioned, 46 patients, median age of 61. By the way, let me tell you again if they were untreated. Yeah, this is essentially frontline treatment for metastatic disease, which makes sense. Obviously, you want to see how all of this works in somebody who's not received it before. If they received prior neoadjuvant or adjuvant, they had to have had a 6-month break or interval between that and starting this triple therapy. And then controlled brain metastasis were allowed. They did check PD-L1 status here. It was essentially PD-L1 negative in the majority of patients, so in 63% or 2/3 of patients, PD-L1 1% or higher in 26% of patients. So that tells you there's a small portion where it was unknown. And then LAG3 was the inverse. So LAG3 was negative in about 20% of patients, and LAG3 was greater than or equal to 1% in 74% of patients. It's of note, though, we don't think that most places are routinely checking PD-L1 or LAG-3 status, but it becomes important when we try to kind of identify for whom this treatment and these types of treatments might be optimally working for. So let's maybe get to safety first, because
before you do safety, can I just ask, in terms of baseline characteristics, anything else that you might pick out or they reported? I mean, maybe LDH or tumor burden or anything like that, just to try and maybe give a sense of the group.
Good point. So 50% BRAF mutated, so that's reasonable. They did have a few mucosals, a few acrals. They don't describe if they had brain metastasis on her. Actually, they do. I take that back. So they had a small portion of brain metastasis, and these were the stable controlled brain metastasis. LDH, they broke off as greater than upper limit of normal in about a third, 37% of patients, and greater than 2 times upper limit in 20% of patients. So it's a frontline metastatic patient population. I think that somewhat tracks. 1 out of 5 being 2 times upper limit and 1/3 being upper limit, but that's to be considered as we think about how to analyze this. So good point. And then liver mets in a 30% of patients. So for what that matters. What else?
Yeah. Well, I mean, well, sometimes people report tumor burden, I suppose. I'm not sure if they did or not. No. But I mean, it sounds to me like there's a fair group. I didn't quite, from the presentation, and I think there's been a bit of subsequent discussion about this, understand necessarily the LDH cutoffs there. I think that 37% had a high LDH period, if you see what I mean, of which, so you don't add those two numbers together to get 57% or whatever it would be with it. Yeah, that the twice the 2x, as you would say, or x2, I don't know how you describe it, is a subset of the 37%. But I think that's fair, isn't it? If you think about the metastatic studies that have been done, over the last several years.
Yeah, they call it 9 out of 46, and so 9 out of 46 is 20%. Yeah. So 9 out of the 46 total patients had 2x upper limit, like you're saying, and 17 or 37% had just 1x, just anything over the upper limit. We see this in metastatic trials a lot, where people use upper limit, 1.5 upper limit, and 2. Has anybody ever written an editorial or looked at where it actually makes a difference in survival? Because this is like a sliding scale that it seems like you could slide to fit whatever your data set supports.
Yeah, so in the past, this is one of those things I think I've tried to get one of my fellows to do in the past several years, to try and analyze as a continuous rather than a discontinuous variable, because I completely agree. It's like, where do you draw the line? And of course, it's a continuous variable. That's absolutely obvious, but we always treat it as a discontinuous variable. And I'm not sure it ever came to anything, or there's anything kind of good that's sort of ever been published on it that I'm aware of. I mean, I'll make an anecdotal comment now, because I like making anecdotal comments, but that, sometimes let's say you've got a patient who's got an LDH greater than 5 times the upper limit, or 10 times the upper limit of normal, or something like that. Those patients certainly still can benefit from Ipi/Nivo, because I've treated lots of patients like that in the clinic. So although I'm saying it's a continuous variable, which it obviously is, that doesn't mean necessarily I think it's linear. I suspect it may not be linear in terms of potential benefit, say from Ipi/Nivo. I mean, you could apply it to other things, but I guess that's the thing I think about a lot. But yeah, good point.
That's a graph I think would benefit us to see what do we think that looks like, where LDH starts to impact benefit. Okay, well, let me tell you about safety then, since that was really the primary endpoint here. So safety of this triple combination, I think the takeaway is it didn't necessarily look any more toxic than the regimens we've seen. That being said, it's a 46 patient study, so we just have to be careful. So 100% of patients had an adverse event. 59% were grade 3-4. 37 of which were called serious grade 3-4s. And if we think of the discontinuation rate, so we could look at other studies and see what the discontinuation rate is for Checkmate 067, Relativity 047. And we see that the treatment-related adverse events leading to discontinuation is about 22%. So as I recall, and we can certainly fact check this, that really places it between the discontinuation rate of 067 and 047. 047 having a fairly low discontinuation rate with their doublet, 067 having a little bit more, a little bit higher discontinuation rate than this, and this triple therapy being somewhere in the middle. And maybe that's expected because the dose of Ipi is lower than an 067. So treatment-related discontinuation rate of 22% from grade 3-4, 41% if we're talking any grade discontinuation.
Yeah, so just maybe to ask about that, right? CheckMate 67, almost done 10 years ago now. Very large kind of international study, often at centres without much experience of using the drugs at the time. We've learned a lot about managing side effects in the last 10 years, and this was a study predominantly done, I think, at very experienced, high-volume European centres. So I think Reinhard Duma and Paolo Ascietto in particular were two of the lead recruiters. These are people who really know how to use these drugs and to manage these side effects. And of course, we've got a highly selected patient population, I suspect. I mean, again, imagine yourself in clinic and you've got a kind of triple therapy and you've got various other options. How could there not, in my opinion, be at least some unconscious bias for patient selection? Is that fair, do you think?
I think that's fair. That's the thing we don't talk about quite as openly, though we might have mentioned it on one of our neoadjuvant podcasts, is that when you're limited with a limited number of slots and you have other good options for these patients, the patients that you end up slotting onto these limited number of slots are a little bit more curated than you necessarily would do in a larger international phase 3, so forth and so on. So your point is very well taken. Treatment discontinuation rates 10 years ago were going to be higher because you saw some adverse event and you let go of the treatment and tried to just manage the toxicity. We're much better at managing toxicity. And there's an inverse to that that's also true, that our reporting of these adverse events and describing them more clearly has gotten better. So now we call hypophysitis when we see it, rather than if you look at the original Ipilimumab, even New England Journal publication, it's really hard to tease out true adrenal insufficiency hypophysitis there because probably people didn't know what they were dealing with. And so we've gotten a lot better at describing those adverse events. And one of those that gets our attention with Nivo-Rela in particular, though it can happen with monotherapy, is the myocardial type of toxicities. So myocarditis, a myositis picture, and then certainly even adrenal insufficiency seems a little bit higher when you add LAG-3 to other checkpoints. And interestingly, when you look at their immune-mediated adverse event table, it's really hard to see that they had a higher rate of myocarditis. In fact, it's not listed in their immune-mediated table here, other than to say they had an additional adverse event of interest, grade 2 myocarditis that occurred in 2 patients. They really didn't have a recurring theme of myocarditis as an issue. Adrenal insufficiency seems to have occurred in 3 patients. So it is interesting that this didn't seem any higher. Just a side note about immune-mediated adverse events. I heard Mike Postel say once recently that Paul Chapman has said, what adverse event do you get when taking checkpoint inhibitor would you say is not immune-related or immune-mediated? Right? Even the fatigue, even the fever, all of this must have a mechanism of the immune system being activated. So why do we even bother to call these things immune mediated? They are just the adverse events. Is that a fair comment, do you think?
No, I think it is a fair comment, isn't it?
Yeah. Can't think
and
of
I think the most conservative way to report this is obviously to report everything.
Yeah.
And I guess that's another potential bias, obviously.
It's just funny to have an adverse event table, then an immune-mediated adverse event table, then a treatment-related adverse event, then a treatment-related immune-mediated adverse event. Just funny.
And of interest. And above a certain arbitrarily defined cutoff, etc., etc., etc. Which I mean, the latter is a particular sort of bugbear of mine. It's like 10%, 15%, 20% cutoff. Well, hang on. I want to know if bad things are happening, even if it's less than 10%, please.
Yeah.
And maybe it just comes back to actually really wanting to see the data and taking a view on it yourself. But anyway.
So now to efficacy. So this triple therapy had both investigator assessed and then what we like to call BICR, blinded independent central review. Central review is usually a little bit stricter when it comes, or sometimes lowers the overall response rate. But I found a couple of things interesting here. So in the investigator review, it looks like the objective response rate was 59%, 17% of which was complete responses, 41% partial. And they went to independent central review. The proportion of complete responses went up. And so potentially that means that investigators were counting lymph nodes that had dropped below a centimeter as still residual disease, and per RECIST, lymph nodes under a centimeter are essentially measured as 0. So radiology was increasing the number of complete responses and decreasing the number of partial. The overall objective response rate went down to 52%. So where does that number strike you, James? This objective response rate in comparison to what was reported in Checkmate 067, what we used to bandy about, but then of course we heard, oh, that's an unconfirmed response rate, and then the relativity objective response rate.
Yeah, well, I mean, people are bound, and I think they were at the time, to be interested in that kind of level of CR without any question at all.
Yeah.
I mean, it's the subject of a discussion in its own right, the whole kind of CR, chasing CRs, I call it. And then maybe it's worth having that discussion another time. But what I was going to say, and I don't think you've said so far, duration of follow-up, because it does speak a little bit to this, actually. Because this was like 4 years or something, right?
Yeah. And that matters when we talk about PFS, because it's a median follow-up of 48, 49 months, 4 years. This is how long we've been waiting to hear this data. Meanwhile, we heard Nadina a median follow-up of 1.9 months. So, we've been waiting to hear this data mature for quite some time. And maybe you're alluding to this. You would like to see CRs increase in a triple combination over double, and you'd like to see that, with this amount of follow-up, maybe we're not seeing more CRs than you're seeing with doublet therapy alone.
Who knows? But yeah, you would hope, wouldn't you, that the CRs that you see on an early readout after a year or two, and the PRs, some of those PRs will convert to CRs, which is what we've seen, I think, with pretty much all the trials, and it's what we see in clinic as well. But I mean, it's an encouraging CR rate without question, I think.
Yeah, but if you're curing the same number of patients with doublet therapy, what's the value of this triple?
Well, quite. So maybe say something about the PFS before we sort of, go into, what's next and how does it fit in, as it were.
And I will say, if we've waited this long for the data, I trust that they did a really good late data cleaning so that the sites entered their most up-to-date data before we saw it. So with the median follow-up of this 40-some months, we can fact check that, 48, 49 months, median PFS has not been reached yet. So that's really striking, because when we think of the median PFS with doublet therapy, you're seeing that at somewhere between 9 and 14 months. So and with triple therapy, it's around 15-ish months. So here we are now, and by the way, triple therapy, I mean BRAF, MEK, PD-1, to be clear. So now we have this triple therapy that doesn't have a PFS yet, with 4 years of follow-up. Caveat that it's these small patients, and as we said, highly curated patient population, maybe not as high LDH and so forth and so on. So I guess to you, the question would be, do we think there's a signal here? What do we do to confirm it? What does the follow-up study kind of look like? And what is a reasonable expectation that we should be getting out of triple therapy? Is it chasing CR, the name of our next reality show? Or is it, look, you've got a PFS, your cancer is not progressing, may not be cured, but it's not progressing, which might translate into things like treatment-free intervals and so forth. We don't know that about this treatment. We don't know who discontinued Ipi and, what those treatment-free intervals look like. But should we be chasing CRs, or should we be chasing a PFS not reached?
Yeah, there's a lot of questions in there. I mean, I don't know if you've got the PFS curves in front of you, and I don't actually, but from my memory, I thought the really interesting thing, if you think about the Ipi-Nivo PFS curve, say in Checkmate 67 or wherever else, it doesn't really matter. There's really that first scans, there's a load of patients who are progressing and dropping off, even at the 3-month interval. And to me, in the absence of the control arm and all the other caveats, it feels like it's not dropping off, and it looks like it's not dropping off in the same way that it might do with Ipi-Nivo. So I'm wondering whether a potential for this treatment might be stopping or controlling those early progressors. That's the thing that interested me most, actually, looking at these data. Yeah, I don't want to talk about chasing CRs now because it's like it'd be like a sermon almost from me for about 20 minutes, but maybe another time. Okay. So then maybe the question would be, if this is going to be developed further, is this a first-line regimen, or given the apparent potency, could it be a salvage regimen? And I think if I was going to, do a trial, I'd probably put it in first line for the reasons that I've said already, actually, with that apparent reducing the early drop-off. I think for salvage at the moment, most people would say that Ipi-Nivo is probably the salvage treatment that they will go to most often. There's quite good data for that. Yeah. You've got that higher Ipi dose there in the kind of quote unquote standard regimen as well. And I'm not sure I'd try and look at this in comparison with that in that type of setting, actually. Plus the fact that Nivo-Rela in the salvage situation on its own actually doesn't really look great. And then you're adding in a bit of Ipi. Are you really hoping for much? I wouldn't be, to be honest. And, I'd say this in public. I am saying it in public. So if you're going to do a first-line trial, is it going to be an all-comers trial, or are you going to focus on people with bad disease? That's a kind of long discussion in its own right, which happens, every so often. And my view on that, actually, is it probably would be better to do an all-comers trial, but, somehow try and allow for the fact that in many ways the major interest for a regimen like this might actually be in the patients who've got worse disease, actually. And then the final comment was going to be, or the final question, I suppose, is if you're doing a first-line trial, then what's the control arm? And again, we talk about this a lot, don't we? So, if you're talking to regulators, then there's a question about what an acceptable control arm might be. Let's say
apparently is a reasonable.
Sorry?
Single agent pembro is a reasonable control arm for the regulatory agency.
Yeah, right. Yeah, and then we've got that's one thing, and then what we in the academic community think about what are reasonable control arms, and it's not like we speak with one voice on this subject, actually, as well. And then, of course, you've got the commercial considerations for the control arm as well. And so obviously BMS make these drugs, and Nivo-Rela, for the sake of discussion, is an approved treatment in this setting. So would you want to do a trial of Nivo-Rela or Opdualag versus this regimen with that little bit of extra Ipi on board and hope that you're really going to get... Sorry?
That's going off patent.
Yeah, and then hope that you're going to get a significant upside there or not? Or, is there scope? I mean, I'd come back to you, actually. Do you think the Ipi dose could be increased any more here? And now I'm thinking about a phase 3 trial or a treatment that then, got a label. Would it be, could it be used, outside big centers?
Yeah, good question. I mean, maybe at this point, I've buried the lead enough that maybe we can just talk about it. So we have designed a frontline study in SWOG, waiting for this 047, knowing that it was coming for over a year now. For 2 years, we've been saying, okay, if triple therapy is out there, how do you design a study? So we have a approximately 900 patient study that will compare triple in the frontline to doublet. Which doublet? Well, part of the study is you randomize the 2 doublets against each other, and then you do an interim analysis that will essentially pick the winner, if you will. This will be hopefully one of the largest data sets we have on comparing doublet versus doublet in the frontline setting, and then the doublet will go up against triplet. This is still going through the process of, CTEP review and so forth. Ideally, by the time we release these podcasts, it will have been reviewed so we can feel good about it. And we think that study is important. You bring up a good point, though, James. Should we be focusing on the worst patients? Because if this cure rate is just as good with doublet therapy, should this maybe be tailored for the higher risk patients? Of course, we would probably, with a fine tooth comb, say 048 was a study of not the highest risk patients. Only a small portion of them were these highest risk. So then how will the data stack up in them? But very fair question. And then we also have a study that will be opening at the University of Colorado, fingers crossed, again, needs to go through the process, investigator-initiated study with BMS backing, that will be this triple combination in the PD-1 refractory population. So that can be PD-1 refractory in neoadjuvant adjuvant, that can be PD-1 refractory as it was given as a single agent combination in advanced disease. And we will essentially stratify by how did you receive your PD-1? Was it single agent? Was it combination? Potentially was it in the early melanoma setting or the advanced melanoma setting? And again, we're just looking to see, does triple add anything in that space? And then Hussein Taubi is running a study called the Trinity study at MD Anderson. And this is really to address that point you made. Could we push this IPI dose further? It's possible BMS has already done some of this and has some of that data, but really just to look more specifically, can that IPI dose be increased? Could it be 1 milligram every 4 weeks? Could it be 1 milligram every 3? And could it go back to this induction and maintenance sort of way that we had learned to give it? And this gets to the point I think you were trying to make, and that we've sort of had conversations about. We know IPI is dose responsive. Paulo Ascierto has that study that he showed 10 milligrams is more potent, more efficacious than 3 milligrams per kilogram than 1 milligram per kilogram. We know in Jed Wolchuk's original dose finding studies, 0.1, 1, 0.1, 0.3, 3, and 10, you could see dose responsiveness. So the history of IPI or CTLA-4 blockade is that it's dose responsive. That is not the story with PD-1 blockade. PD-1 blockade is fairly flat. You give one dose of PD-1, it is the second dose and third dose, we're not really sure what they're even doing. And we don't see this dose responsiveness in there. And the unknown, maybe what's the term we should use for the unknown? The sort of, it's not a red herring. Anyway, you'll tell me what the charming British phrase is for this. But the unknown variable, the wild card, if you will, is LAG-3. How much LAG-3, is LAG-3 blockade dose responsive? Is 160 the optimal dose? Is it the safe dose? If you give 480 of LAG-3 inhibition, so 480 of Nivo, 480 of LAG-3, would you get a different dose response curve? Do we know anything about LAG-3 and its dose responsiveness? Do you know anything?
No, I don't think we do. Certainly not from good numbers of patients. So would this be an elephant in the room or not? Or does it not really qualify for that level of description, would you say? Something smaller than an elephant?
Yeah, it's smaller than an elephant. It's just the unknown. And the elephant in the room is sort of like the known thing we're not talking about. But good one, yeah. And then you brought up another point. You were asking, can we push the dose further? And then were you alluding to toxicity in some way?
Yeah, definitely, because more. I mean, you just said it for efficacy, but obviously for toxicity, more CTLA-4, more toxicity. We know that, and I think, this is an important point. At experienced centres with people who really know what they're doing, then you can do this. But if you start pushing too hard, especially, there's the regulatory question in due course, where regulators might look at a study and say, well, actually, it's positive for efficacy, but they have concerns about the toxicity. And the reality is, in the quote unquote real world, toxicity is bound to be higher than it is in the controlled environment of early phase studies at academic centres. So I think that's just, I don't think there's any easy or right answers to any of this, but I guess it's kind of interesting.
Yeah, I would say we also shouldn't shortchange our community oncologists who are using these regimens and taking care of these patients. They're very sensitive to this toxicity issue, because for them, it means having to corral specialists that may not be under their roof to take care of a patient's side effects that was caused by the treatment. So I have seen community oncologists in the US use the Checkmate 511 inverted dose of Nivo Ipi even though they realize that the data was the study was powered for toxicity, not an efficacy, but they will say for them, toxicity rules the day because it means less support needed for these patients, less hospitalizations, so on and so forth. And that matters when you're a practicing oncologist. So I think if ultimately triple therapy is effective, but leading to the same number of cures as double therapy and potentially comes with a higher adverse event sticker price, I do think that it will resonate in the community where they will say, I'm not sure I see the value of triple. If I can cure just as many patients with double and then use what I didn't use as a salvage regimen. So I think that's why these confirmatory studies will have to be done. We could use these at academic centers for sure, but if we really want to get this where the majority of melanoma patients are, we have to answer some of these important questions about safety and then.
Yeah, so that I was going to say that ended up quite a long discussion, over half an hour. That's good. So anything else we need to say? Go on.
I think just to remind people that this has not been published, so this is not available in published form yet. It was really just presented at ASCO, but we thought it was important because we'd been waiting so long to see this data. So that's why we decided to just give it a discussion here. But that's really it for Checkmate. For what was the study called again? Relativity.
Relativity. We're not cutting that out because it's fine. Yeah, well, thanks. That was great. Really interesting study. Congratulations to the investigators as well. Look forward to seeing a manuscript, actually, one hopes, before too long. And I guess watch this space. So thank you. So, fact check on Rela 48. First thing to say is the citation, which is ASCO Annual Meeting 2024. Paolo Ascietto and colleagues. Reinhard Duma was the senior author, and the abstract number was 9504. And the minimum follow-up in the trial was 49.7 months.
Right. And then we had a discussion of the components of Relativity 048, nivolumab, rlatlimab, Ipilimumab. Were they all separate infusions? Was it the fixed dose combination of Nivo Rela? The doses were what we're familiar with for Nivo and Rela. It was 480 of Nivo, 160 of Rela, and they were co-administered. And then Ipi was given 1 milligram per kilogram every 8 weeks. Nivo Rela every 4 weeks. Great. Done.